numbers are increasing with time in Malawi, and you find that most of maybe the clinicians who are involved don't have as much knowledge as to how to manage these patients with breast cancer, but not only on the human resource part, but also lack of other resources that you could use as part of the management, like treatment for these women is also quite lacking as well. In the whole of Malawi, we only have 3 pathologists who are working there, and none of these actually belong to government. Where I was mentioning a woman who came 2-3 years ago, had a mastectomy done, and now was feeling quite unwell at home and decided to come back to the hospital. And on history, it was found that she actually had a mastectomy for a breast cancer. Of course, it wasn't mentioned in her notes at what stage it was, but when we did further investigations, we found she already had metastasis to her chest, where she had several lesions on her chest X-ray itself. And it was sad to think about it, because after the mastectomy, she wasn't offered anything else. It would have been ideal maybe to do chemotherapy or even radiotherapy, which are things that they don't have easy access to. Radiotherapy, there is no way in Malawi where we offer radiotherapy. It's not available. And other people, if they have money, can go to Tanzania or Zambia, but that's not easy for an average Malawian. I would like to, at least maybe as my colleague Warnie is working on the plastics, maybe we can relieve some of their work by doing some reconstructions. So at least if I know as a general surgeon how to do reconstructions for these women who will do mastectomies, maybe we can relieve a bit of the workload that they have in their unit. At the same time, I'm also hoping to learn the proper protocols that one can follow in order to treat these patients with breast cancer. And in those protocols, if I'm finding that I do not have adequate resources, I should be able to now start thinking more of, okay, which other way can I take with this patient that I can give them the best care that I possibly can. Yes. I think it's a big connection. I mean, as I was growing up, he always used to talk about Glasgow. There are many pictures in the house of his graduation here, and so it's something quite close to heart somehow. Yes. Now we seem to have more females in the department who are training. But at the time that I joined the department, that was 2008, I was the only one who joined, and then it took about 2 years. Then another female joined the training program. But then since then, we've had more and more females joining the department. It is a challenge. It's not easy being a female, and you have to think of, maybe you think of getting married, and then after getting married, you think of having children, and it's not always easy to balance being a surgeon and having children, having to look after them. You may tend to miss a lot of moments in the child's growing up because you're busy at work, so it's not always an easy thing. It's very challenging. Yes. Their contributions would definitely make a big difference, because I think as part of the whole program, it's not only breast surgery or plastics that they're going to be getting trainees to come here, but people in other fields as well. So you're targeting a whole big population with different conditions. So I believe that the contributions that will be there will play a very big role in the medical sort of delivering medical practices in Malawi, like the surgical skills and all in different areas. This is the way that our department will start growing and making a big difference.